In this series of psychiatric mental health discussions, we will explore the role of the mental health nurse as it relates to various diagnoses and situations. Keep in mind that mental health nurses have a responsibility to maintain strict ethical and legal professional boundaries while caring for mental health clients to preserve their safety and rights. If we view mental health as a continuum ranging from mentally well to mentally ill, it is easier to accept that mental wellness is not merely the absence of obvious illness or disease. Our book defines mental health as the successful adaptation to stressors from the internal or external environment, evidenced by thoughts, feelings, and behaviors that are age-appropriate and congruent with local and cultural norms. Therefore, they have no functional impairment and no mental illness. Mental illness, on the other hand, is based on incomprehensibility or our inability to understand the motivation behind the behavior of certain individuals. So mental illness is very culturally defined. And their behaviors are so significantly disturbed, including their thoughts and emotional regulations, that they have an interference in daily functioning and maladaptive responses to stress. And then we would consider them mentally ill because they cannot function on their own. Stress is how an individual responds or reacts to any change that requires an adjustment or a response. This can be a physical, mental, or emotional stressor, and each individual's response will vary based on their current coping mechanisms and abilities. Their response may be a healthy or positive response, which we call an adaptive response, and the behavior maintains the integrity of the individual. So they quickly return to equilibrium and continue on. Or they may experience an unhealthy or negative response, which we call a maladaptive response, where the behavior disrupts the integrity of the individual and may become persistent. We see this physical response in the fight or flight syndrome. So the stressor triggers the sympathetic nervous system, and norepinephrine and epinephrine are released from the adrenal medulla, causing an initial surge in energy and glucose and blood pressure and perfusion. And then if the stress is not immediately resolved, the body will start to secrete cortisol from the adrenal cortex. And this becomes what we call the resistance phase of the general adaptation syndrome, where we go into this kind of chronic stress period. If we don't successfully resolve the stress, we will eventually reach the phase of exhaustion, where we have a loss of mental and physical health, and even can lead to complete exhaustion and death. So sustained stress causes long-term problems. And we know excessive stress definitely leads to illness. So when we're doing a medical intake, we always ask questions about overall stress because we know that there's a correlation between the two. Physiologic responses to stress vary depending on the amount of stress the individual is experiencing. In mild to moderate stress, there will be subtle changes such as changes in sleeping and eating, restlessness that will look like foot or finger tapping, fidgeting, nail biting, or pacing. If the person's experiencing maladaptive responses, then they may also start self-medicating with things like alcohol, nicotine, caffeine, or even illicit drugs. Prolonged stress, we know, leads to things like colds and flus, asthma, stomach ulcers, eczema, skin disorders, heart disease, cancer, depression, and even PTSD. The mental health nurse should work with the mental health client at developing adaptive coping strategies such as self-awareness, relaxation, meditation, interpersonal communication with a caring other, problem-solving skills, and utilizing distractions and therapies such as pets and music to help alleviate some of those stressors. With mild to moderate anxiety, we also see employment of ego defense mechanisms. The ego is the part of your personality that's kind of like your rational brain that kind of plays the peacekeeper between your id, which is your immature self, the one that wants instant gratification, and your superego, which is the idealist who thinks, what everything should be perfect and exact. And the ego is the one that tries to seek kind of compromise. Our ego then kind of becomes like our moral self and the person that we project to the world, the face that we put on every day, and the way that we kind of go about ourselves. So it's how we choose to live our lives, and like the moral, ethical person that we are out in the public. So when we get stressed, that our ego becomes threatened in terms of we want to sway more towards like the id for instant gratification, or we want to sway more towards the superego, and like really take kind of a high ethical stance on things, and it's hard on our rational self to really sway one way or the other. So these ego defense mechanisms, some are more adaptive than others, and I've kind of broken them up into ones that are actually kind of healthy, ones that are intermediate, like sometimes are used healthy and sometimes are used in a harmful way, and ones that are considered immature or definitely harmful, that are maladaptive. They're always trying to protect the ego, whether the person realizes it or not. And again, it's in an effort to relieve that mild to moderate anxiety. We consider them maladaptive when they use them to such a degree that the defense mechanism interferes with the ability to deal with reality. The ones that are immature or maladaptive are the ones where the person really just can't cope or recognize that they're existing. And when that happens, we consider them to be self-deceptive, which means that the person doesn't realize that they're happening. They can be, though, very self-protective, especially the healthy ones, so they should not be eliminated. But if you recognize that someone is employing or utilizing these ego defense mechanisms, you should, as the mental health nurse, have a conversation with them to explore their use instead. So just to focus on a couple of these. Rationalization is when we make excuses for behaviors, and therefore we're not actually facing the problem. Regression we talked about, and that's like going backwards. So when you've achieved a milestone and then kind of regress again. Repression is the involuntary blocking of an event or a memory, and that oftentimes requires like therapy, even hypnosis, to recall those events. Isolation is a very dangerous one. This is where people separate a thought or memory from the emotion, but it also could mean avoiding contact with others and really isolating themselves from people. Projection is where somebody is feeling something and they don't like it, so then they kind of project that feeling onto someone else. So if you're mad at someone but you feel guilty about being mad at them, then you project that feeling onto them and say that they're mad at you instead. And denial. And denial occurs when you refuse to acknowledge that the situation exists. So those are the ones that are kind of the most dangerous because there's no coping involved with them. There's no analyzation or discussion of the events that took place. The intermediate ones, so the ones that could be used in either way, are displacement. And displacement is where you transfer feelings from one target to another that's considered less threatening or neutral. This is harmful when you're displacing the feelings onto another person. So you get angry at work and you come home and you kick the dog. But it can be healthy if you have a healthy outlet. So if you take up kickboxing or something like that, and you're taking out your aggressions in a safe and healthy manner. Reaction formation occurs when you have unacceptable or undesirable thoughts or behaviors, and instead of expressing them, you exaggerate opposite thoughts or types of behaviors. So your book gives an example about someone who hates nursing but goes to school to please their parents, and then tells everybody how wonderful nursing is, even though they hate it. But at the same time, they may be aware that it's happening, and you may be able to talk to them about their thoughts and their true feelings. Compensation is where somebody over compensates or covers up for a real or perceived weakness by kind of enhancing a different trait. So if you have somebody who has maybe a vision deficit, maybe they have enhanced whatever, hearing, or they learn to play the piano by feel or something like that. But it's also can be positive if they realize that they're doing it on purpose, right? So it's negative if it's maladaptive and they're doing it in an effort to not have to deal with the situation, but it's positive if they do it on purpose. And then undoing is the last one that can kind of go either way, and that's when you symbolically cancel out an experience that you find unpleasant or intolerable. So that's when you have wronged someone or done something bad, and then you attempt to make up for it. So again, if you do it on purpose, like the book gives an example of buying flowers after yelling at your wife, and you do it with the purpose of saying you're sorry and meaning you're sorry and making up for it, then that's a positive. But if you, buy the flowers and don't talk about it and pretend like it never happened, then that would be maladaptive. Intellectualization is considered healthy, and that's an attempt to avoid expressing actual emotions associated with a stressful situation by using logic, reasoning, and analysis. So you're thinking about the situation, but you're just kind of separating yourself from it. Different than isolation, because you're really thinking about it and you're analyzing it. Sublimation is rechanneling energy into something that's more socially acceptable or constructive. And so that's like your book gives the good example of the mother whose son was killed by a drunk driver, and so she becomes really active in the Mothers Against Drunk Drivers. So again, she's taking a forward stance. That would be things like the Condition H and different laws that occur in healthcare would be good examples of sublimation, where families have come forward and use the negative experience to create a positive outcome. Suppression is where you voluntarily block something until you're ready to deal with it. So we use this daily as nurses while you're on the floor. Something's going bad at home or in your personal life, or you don't feel well or whatever, but the second you step on the floor, you put on your game face, you do what you have to do, and then you kind of block those thoughts out while you're at work, and then once you're done work, you can start thinking about them again. Identification is an attempt to increase self-worth by acquiring certain attributes and characteristics of someone who you admire. So again, you could go overboard with this. It could be maladaptive, and you could not even realize that you're doing it, and start to stalk or clone somebody. But it could also be very healthy. So if you have a mentor that you really can identify with, and you want to be more like them, then you can use that as a goal and work towards that goal. And then introjection, and that's where you integrate the beliefs and values of another individual into your own ego structure. And so we use this like with children, where we're teaching them their value system. They gain that from their parents. But again, if you're doing it on purpose and you're watching what someone does and you want to be like them and you're kind of modeling their behavior, then introjection can be positive. But if you don't realize that you're doing it and it's a blind faith kind of thing, then it could be potentially a negative, but it's usually more positive. So those are our ego defense mechanisms. And it's just important to remember that, again, they can be positive, they can be negative. They're maladaptive if they interfere with your ability to deal with reality. But they shouldn't be eliminated altogether. Instead, we should try really hard to explore them more and help people understand what it is that they're going through and how to cope with it. Severe anxiety, then, for extended periods of time can result in psychoneurotic patterns of behavior. And the two that we're going to look at are neuroses and psychoses. And so neuroses occurs when there's excessive anxiety and the person is very aware. So they're aware that they're in distress and that they're aware that they're using maladaptive or negative behaviors, but they're unaware that it's caused by anxiety. The big thing is that they totally feel helpless to change the situation. So they say, like, I'm so anxious, things are going so bad, like I can't make good decisions, but they feel very powerless and they feel like they can't change anything. They have not lost contact with reality. So they're fully grounded, they understand what's going on, but they have enough anxiety that they can't make the connection between what they're experiencing and the cause. Psychoses have patients who are psychotic basically have a significant thought disturbance with a loss of contact with reality. They tend to have actually very flat affects or seem withdrawn. There's minimal emotional distress. They're unaware of their behaviors. They're unaware of any of their psychiatric issues. And characteristically, they have this flight from reality to a safer or less stressful world. Grief is the feeling that we experience when we have lost something, and it can be an actual loss that somebody else could, see or experience with us. It could be a loss that other people can't perceive. That would be like the loss of feeling of femininity, or it could be a kind of an anticipatory loss where you know that something's going to happen or change, and you start thinking about it ahead of time. Kubler-Ross talks about the fact that there are different stages of feelings and behaviors that people go through when they are experiencing a real, perceived, or an anticipated loss. There's the denial stage where they think like, no, this can't be happening, that it can't be, whoever that person or that can't have happened. There's an anger stage where they, can't justify what happened, so they get mad, why did this happen? Why did it happen to them? Why did it happen to me? Like, this isn't fair. There's a bargaining stage where, I'll go to church, I'll do this, I'll do that, take me, not him kind of thing. And then a depression stage where the person's really feeling the full impact of the loss and they feel very sad, and oftentimes, they'll experience some despair. The last phase of this, or the last stage of this, is acceptance. And so really all of these stages can be experienced in any order. They can be experienced multiple at a time. You can go back and forth between them, but acceptance is considered kind of the final stage. And in the acceptance stage, you feel a feeling of peace regarding the loss, and that you can focus on the actual relationship itself and look back and honestly talk about the loss and what it means, both positively and negatively. people, even once they've gone through acceptance, can continue to have grief that will reemerge from time to time with response to triggers like anniversary dates or locations or similar, things that remind them of that person. Nurses who work in critical care or elderly individuals who may be experiencing like numerous losses, anybody who has repetitive losses in a relatively short time are at risk for experiencing something called bereavement overload, which is where you basically have kind of almost like a PTSD based on grief, right? So it's way too much grief all at one time. And really the concern for that is that every time you experience a loss, you have to kind of go through this process of resolving it. And when you experience a lot of losses right on top of each other, it becomes more difficult to successfully deal with all of those losses and resolve your feelings. Maladaptive grief responses then occur oftentimes when you have like a really sudden significant loss, like the death of like a parent or a loved one or a child that you really weren't expecting. So something that was like really traumatic or significant. Think about like 9/11 and the losses that all those people, experienced. And so those can lead to maladaptive responses. Prolonged grief occurs when the person years later is still preoccupied with the person that they lost or the thing that they lost. And they're often stuck in both anger and denial phases. So they're very mad, they still can't rationalize or justify it, and they deny that it even really happened. You'll see these people oftentimes will keep, the bedroom the same. Sometimes they'll like pack lunches, they'll celebrate birthdays, things like that. So they really can't let go. In delayed and inhibited grief, the person is stuck in the denial phase, and that causes them a lot of anxiety because, part of them knows subconsciously that the loss has occurred, but they're refusing to deal with it or acknowledge it, and the body really just can't balance that out, so they start to have severe anxiety. With distorted grief, they get stuck in the anger phase where they know that it's happened, but they just can't rationalize it. And this leads to pretty severe depression. So those are the key points from chapter 1. And next we will cover chapters 2 and 3.